Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have a patient who attended with bilateral fully occluding earwax. We're just commencing with their left ear first, and they've got quite a hairy entrance to their ear canal. See, those hairs are protruding outwards from the posterior to the back section of the lateral canal. So when we say lateral, I mean near the entrance. The wax in this ear was a bit firm and dense, so I've just instilled some medical grade olive oil spray to help soften and loosen that, which has worked really well actually. And I've managed to release it from the back of the ear canal, and what we're trying to do now is wriggle it out the ear, but you'll see it's quite tough bringing this through. It got trapped past the second bend and in front of the first bend, so in the outer third of the ear canal. And I had to revert to using the right angled ear hook to finally extract it fully from the ear. So I'm just stretching the ear open, and I've got a suction grip there, and I'm using these little wriggle movements to bring it forwards. It's quite matted, the surface of the wax plug. It's quite dark, so we know it's been there for a while. It's oxidized. And this is where it was a bit of a struggle. It was just too big a plug, and at times I was pushing it back in. You may have noticed that, so just be careful. So I've just gone a bit higher up, and I'm just working at the back here. So as I'm bringing this out, I want to navigate the bend of the ear canal. So as we enter the ear canal, first of all, the ear canal veers off to the right, and then it veers off to the left. So where that flesh is at about 9 o'clock on screen on the left hand side, that's the second bend, and beyond that point the ear canal veers off to the left, and on the right hand side where those hairs are protruding outwards, that's the first bend. So as we enter past the first bend, there's a slight deviation of the ear canal to the right, and then as we approach that second bend to the left, it deviates the opposite direction, and it's more or less straight. There's a bit of a curvature as we approach the eardrum. So where the suction probe is, that's the first bend, and see, I'm really giving it a good wriggle. So it's trapped in the isthmus. An isthmus is a medical term. It can be used in other fields as well, but in the medical field, it's just a narrowing. And in the ear canal, we've got two narrowings. We've got one here, exactly where we are at the moment, between the first and second bend. And then there's a further narrowing deeper in the ear canal, just in front of the eardrum, about 0.5 centimetre away. That's the second isthmus. I'm just using the right ear hook, managed to prise out this wax plug. It's separated into two, and that's just in the concha bowl. So we're going to re-enter, and we've just got these pellets. I like to this is probably the best way of describing them, and they are lodged very deep in here, quite dry. I'm just using the fine end suction probe here, and I'm just going to spend a bit of time now clearing this out. Now, interestingly, in both this patient's ears, once we've removed the wax, they still felt a bit blocked. Now, that can happen for a number of reasons. Maybe that this patient's got an underlying hearing loss. Therefore, when you're removing the earwax, it does improve their hearing, but because of their hearing loss and they're not hearing certain frequencies as well, they can sometimes perceive a sensation of being blocked, particularly if someone's got a high frequency hearing loss. So when we do a hearing test, we test your speech frequency range between 250 hertz and 8 kilohertz. And if someone's got a high frequency hearing loss, let's say from 2 kilohertz onwards, which is kind of normal for age-related hearing loss. We tend to lose our higher frequencies before we do our lower frequencies. But if you've got a high frequency loss, patients sometimes can experience a blocked, a muffled sensation. That's because the high frequencies provide the clarity in speech. They're the consonants, the beginnings and endings of words. Whereas the lower frequencies, they provide more of the volume in speech, so the vowels. And when you can hear the vowels significantly better than the consonants, patients can sometimes feel that their ears are blocked. They've got cotton wool because everything's muffled. They're not getting the clarity. So that's one potential reason. They may have a temporary threshold shift. So when we perform microsuction, sometimes patients, very rare, but they can experience a short-term reduction in their hearing thresholds. And that's because sometimes microsuction can be a bit noisy. Typically that resolves within a day or two. but it's quite rare, but that's one of the potential reasons. But I kind of know it's not either of, well, I know it's not the temporary threshold shift, because this wax was fully occluding. The patient could not even hear the suction machine when I was performing the procedure. And when I was performing the procedure in this patient's left ear, I got a really good suction grip, which actually reduces the noise levels because there's no air escaping. And then the last bit of the wax plug I removed using an ear hook. Now, but what happened in this case, and it was both ears, again, when you perform microsuction, you're creating a vacuum, or you're trying to create a vacuum in the ear canal, and that can displace the eardrum. The eardrum can be pulled outwards, and by pulling the eardrum outwards, and it may not be visible when you're doing it, could be a very small change in the eardrum position. But when the eardrum is pulled outwards, so it's attracted by the suction, it actually lowers the middle ear pressure. So by pulling the eardrum outwards, the middle ear cavity increases, which then as a result means the air pressure reduces. So there's a differential in air pressure behind and in front of the eardrum. So what I did in both ears, I performed a pressure test called tympanometry. And what we do, we create an airtight seal at the entrance of the ear. We use a rubber tip or silicone tip. And the tympanometer machine does a pressure sweep, so it goes positive and negative and then back to zero. So it's moving the eardrum forwards and backwards and back to where it should be, 0 decapascals. Just by performing a tympanometry test sometimes after performing microsuction, if a patient still feels blocked, really helps. Of course, they may have had an underlying middle ear problem before, so they may have had a blocked eustachian tube, which means the air pressure was already negative, but that wasn't the case in this patient. It was just post-procedure. So the right side, the patient had been using drops on this side, so the wax was a bit softer, but there's a little puddle of oil there where the wax is. You can see some of that oil. So as I'm suctioning this wax that's on the eardrum, this oil's also being suctioned away. So it's very dry, crusted. And it's going to mop this bit at the entrance. They've got quite a narrow, bendy isthmus, the first isthmus. And in this ear, the patient's inferior recess is quite prominent. So as we approach the eardrum typically, not always, but in most people, it narrows about 0.5 centimetre in front of the eardrum, so we call that an isthmus. Then it widens, and it normally widens on the front part of the ear canal where we kind of are here, and also at the bottom of the ear canal. So this is their inferior recess. You can see they've got quite a pit there. So they've got a very prominent inferior recess. They really don't have an anterior recess, actually. So the ear canal doesn't really narrow on the front section like it does in most people. In fact, if anything, there's a posterior recess. So, well, I wouldn't even say they've got a posterior recess, but if we had to say they've got one or the other, I would say they've got more of a prominent posterior recess than an anterior. But yeah, the floor of the ear canal, the basin near the eardrum is quite prominent, and that's where a lot of the oil got trapped. So again, just gonna mop up some of this crusted wax. Just gonna hover over. So this patient has to attend yearly, so it's an annual thing. So really happy with that. That's the wax that got trapped at the tip of the suction probe in both ears. You can see it's very dark. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.